So this is the first case. This is a 22-year-old lady who presented to medical department with fever, and upon examination, she has some lymphadenopathy as well. The uh, biomedical scientist from the lab called you because he has seen some abnormal cells in the blood film. So he wants to see you this blood film and take over the case. So anyone from the attendees who is volunteer to go for this case?
I can try.
Okay. So this is the power 10. I will go through the slide for a general view, and then I will go to the 50 slide. Just to give you a hint, this case came in the FRCPath exam twice in a row, and it is very common in the short case of morphology. I will go to 50 power. The red cell morphology. Platelets and the white cell. Right. So now you can report the blood film. This is the usual question in FRCPath. Report the blood film.
Okay, the blood film shows a presence of some atypical lymphoid cells with which are variable in size. Some are small in size and some are medium and having irregular nuclear contour, and some have round nuclei, whereas the cytoplasm is also variable. And some of the large size cells they show um, abundant cytoplasm, agranular cytoplasm, and scalloping around the RBCs, whereas the neutrophils and are preserved, and the RBC morphology is unremarkable, and there is mild thrombocytopenia. Uh, but I would suggest the flow cytometry
Why flow cytometry?
to rule out whether they are reactive or they are clonal for the immunophenotyping of these atypical lymphoid cells. The first thing which comes to my mind was infectious mononucleosis, keeping in uh, view the patient age, young age, the presence of fever and lymphadenopathy. I don't know the status of spleen because the chromatin of these atypical cell, it seems to be mature. It's not like the immature like which we do have in blast. And they have abundant cytoplasm which is scalping around the RBC. So infectious mononucleus came to my mind. So that's why I advise flow cytometry to differentiate it from the malignant morphology, and we
But
can advise
you haven't
that.
seen any blast here.
Sorry, any blast?
You haven't seen any blast here.
Yes, they don't look like blast to me.
In that cases, we do
They
not
seem
send.
reactive.
Yeah, so we do not send for flow cytometry. The blood film shows lymphocytosis, most of which are atypical. They are different in size with basophilic cytoplasm and mature nuclei.
Mhm.
The red cells and platelets are normal. The blood film is consistent with reactive nature. Further investigations are required to reach the final diagnosis. You,
Okay, we do
you
not advise the heterophile antibodies or monospot test, or we just say, okay, rule out.
yes, so this will be the next question, what investigation you will do. But to complete the report, you will write your findings. You will mention most probable consistency, like this film is consistent with, and suggestion to what investigation you would do next. So the investigation you would do next will be,
The heterophile antibodies, that is the monospot test, or you can ask for EBV specific antibodies.
yes, EBV serology or PCR. Um, we also do here HIV and hepatitis serology for such patient as well, and monospot test or EBV serology. And then the third question would be, what is the most likely diagnosis here, given the patient age and presentation?
That is infectious EBV induced viral infection, most likely infectious mononucleosis.
Yes, because the patient only presented with fever and few lymph nodes. They did not mention any B
Mm.
symptoms, and the blood film does not show any immature blast. And there is scalloping around the RBC, which is a feature of reactive lymphocyte, and they are basophilic as well. There is no nuclei inside. So this case comes twice in the FRCPath exam. uh, in the
If you don't
recent,
mind, can you repeat okay, my final report that the presence of these atypical lymphocyte consistent with
yeah.
infectious
So
mononucleosis?
in
Mhm.
any report, when they ask you report the blood film, you will first write the findings in the blood film, and you have to mention the most obvious finding first. This blood film has lymphocytosis. You will see first the blood film has lymphocytosis and a few words about the lymphocyte. Not much explanation about the lymphocyte, because sometimes you will address the GP. The blood film will be from the GP. The GP do not understand these things. So only few words in the description of the cells. The blood film, this blood film shows lymphocytosis. The lymphocytes are irregular in shape and size, with nuclear maturity, having basophilic cytoplasm. The red cells and platelets are normal. The blood film is consistent with most likely. You will always write most likely or most probably because you have to confirm it on further investigation. You will not say that this is infectious mononucleosis. You don't know. Maybe you do some test and it comes out something else. You will say the most likely or most probable diagnosis is consistent with uh, reactive nature, and then you will suggest investigations. You need to do further investigations to confirm your diagnosis. So, three parts: description of the cells,
Mhm.
most likely or most probable diagnosis, and what investigation you will do. So, this is the advice part. Then you will get 5 out of 6 marks or 6 out of 6 marks.
Or in a further investigation, we can just say viral serology, or we have to specify the viruses, whether it's HIV, hepatitis, or it's
Mm.
like we are,
Because
as I am suspecting. Mhm.
because you are suspecting the infectious mononucleosis, which is because of the Epstein-Barr virus, you can mention monospot test and EBV serology or PCR. And in such cases, because it is a transmittable disease, so we always do other viral serology as well, like hepatitis B, C, and the HIV.
Okay, thank you.
Yeah. So this was the first case. Now, I would like anyone who has applied for the exam. Yes, I need a volunteer, please.
Hmm. Hi, Amar. I will do it.
Okay, good. So this is a 36-year-old lady who presented to emergency department because of extreme tiredness. She cannot carry out the daily activities because of the lack of energy. She had blood tests done and the uh, lab called you because the hemoglobin is on lower side, 105. The white cell count is 54, and the platelet count is on lower side as well, 140. The biomedical scientist is worried for the abnormal cells and high white cell count in the blood film. So this is power 10, a just general overview of the blood cells. Okay, I will go to power 50. Okay, so you can start reporting the blood film. The first question is report the blood film.
Yeah, I can see uh, mononuclear cells increase in number, and these are medium to large in size, and they have like irregular nucleus with open chromatin. Some of the nucleus showing prominent nucleoli as well, whereas the cytoplasm is moderate or adequate. Most of the cells showing agranular cytoplasm, but there are some inclusion I can appreciate in the granulocyte, but frank or rods I cannot appreciate. Some of the like blast cells showing indentation or irregular nuclei, even I can like a few nucleus showing cup shape nuclei as well. Mm, but for my opinion, I can't say it is promyelocytic. There is no abnormal bilobed appearance in the blast, whereas in red cell there is an isocytosis. They are like mm, normochromic. Platelet are reduced. Um, I guess it's not like 140, but platelets are seen. Few neutrophil also. I can see few neutrophils. Uh, it's like most probably like it's acute leukemia, and I would advise bone marrow aspirate, refine, flow cytometry, and cytogenetics and molecular panel.
Okay, yes, I agree with the blood film reporting.
Yeah,
Uh, they have fish mouth appearance here
yeah,
and or cup shape.
yeah,
These are cup shaped blast,
yeah, cup
consistent
shape.
with
Uh,
consistent with
consistent with
acute leukemia, and you would
yeah,
do further investigation to confirm your diagnosis.
yes.
Okay? So, what is the minimum genetic test that you would do in a new AML patient as per BSH 2022?
Yeah, I would like to know FLT3. I would like to know NPM, and I guess one other is which is translocation 1616. I genetic I just forgot. It's NPM FLT3 and inversion 16 and translocation 1616. There is one more. I just want and of course it's not APML, so I don't know whether I should write PML, RA, RR, RARA, rungs 1 and rungs like 821 translocation. I would also would like to see.
Okay. So, this table is given in the BSH
Yeah,
guideline.
in
But
BSH guideline.
remember it, it will be asked from you in the Viva or in this morphology question if it is there. So there are four categories. You will do fish for inversion 16, 8, 21, and KMT2A. This is the
Yeah,
first category. Second category is karyotyping, to know about any other translocation. Third category is molecular, NPM1 and plate 3 with ITD or TKD. This is the third category. And the fourth category is NGS panel. So
yes.
on any um, suspected acute myeloid leukemia, you will do this panel. Now, the examiner can ask you in Viva, this um, this acute myeloid leukemia is NPM1, okay, and whether this is CD34 negative or positive.
CD34 negative. NPM is the CD34 negative.
Do you know any other acute leukemia who is CD34 negative?
It is APML and megakaryocytic
KMT2A.
KMT2A.
So the next question would be, um, what management you would do? This is a broad question, and the examiner wants to listen to your management of this patient.
Yeah. In management, she is 36-year-old. I
Mhm.
would do baseline, CBC, renal, liver, viral, and as well as the pregnancy test. And secondly, I would see the blood counts, and like if it's more than 50 or high, any symptoms for the leukocytosis, electrolyte monitoring, and then if it's likely abnormal electrolyte, then the TLS surveillance as well as the management. And first is the supportive care, admission, supportive care, discussion of the diagnosis with the patient, and then probable further treatment, discussion about the treatment, and uh, this is like.
Mm. So the examiner here would like your approach here.
Yeah.
Uh, so if you have found this picture in the blood film, you will
Yeah.
explain to the patient that we are suspecting a hematological malignancy in your blood film. So we need further investigations to carry out, which include a bone marrow biopsy. And then you will give her a leaflet of bone marrow biopsy and explain how the procedure is done, and, and mention that it is an urgent one. The patient would say, well, do I have acute leukemia? The examiner would pretend as a patient. He would say whether I have acute leukemia. You would say, uh, at the moment, we cannot say with 100% surety that this is acute leukemia, but this is a suspicion that something is going on in your blood film. That's why we want to do bone marrow biopsy to confirm that. And then once you have done your bone marrow biopsy, and usually the flow cytometry is very quick. If you ask your HMDS, local HMDS, they will process the sample within 24 hours. So you can mention to that we will request our HMDS to expedite the procedures. And if there is a flow cytometry which is consistent with acute leukemia, you will mention to the patient that we would need further investigations to to see your organ functions like echocardiography, your liver function test, kidney function tests, which are done normally, but ECG, chest X-ray, and lung function tests will be done uh, to see the fitness of the patient for the chemotherapy. Once the bone marrow biopsy confirm the acute leukemia, then you would do the breaking bad news with the patient and give her leaflet of acute myeloid leukemia and offer her the treatment options, which are obviously the chemotherapy. But depending upon the patient status and comorbidities, you would decide whether to give her intensive chemotherapy or a non-intensive or single agent chemotherapy. She is 36. She is fit for intensive chemotherapy if she has no comorbidities. And you mentioned that you would exclude pregnancy as well because chemotherapy has deleterious effect on the pregnancy. And after that, once the patient agree for the chemotherapy, you will discuss the case in your MDT, present your case, present your treatment option, and if the MDT people agree, then you would proceed with the chemotherapy. Now, if this patient is fit, no comorbidities, no pregnancies, what intensive chemotherapy you would give to this patient?
It is 3+10 um, uh, ADA and the cytosar. according
What
to
is 3
the,
plus?
yeah,
What is 3 plus 10?
it's idarubicin and cytosar. Ida is three for 3 days, and cytosar for the 10 days, day 1 to day 10.
Either flag ida or DA.
Okay.
And yes. And then, uh, according to the BSH guideline, standard of care is either DA or flag ida, but depending on CD33 or FLT3, you will
Yeah.
choose
Uh,
Mylotard.
Mylotag.
Okay. And then after 2 cycles of DA, you will give her the high dose, 2 cycle of high dose cytarabine. And then once the
Amir,
patient,
I'm just interrupting you. Sorry. Is it an intermediate dose RAC, or it is a high dose? Because
high dose,
in some article I have read, it's now it's intermediate RAC,
the BSH guideline says high dose
high dose
cytarabine.
RAC. Okay, high DAC.
Yeah. And once the patient is in remission after the first CR, then you will request your transplant colleagues whether this patient is fit for transplant or not. If this patient was not fit for intensive chemotherapy, what are the options you have?
It's not fit for transplant.
Not fit for transplant, not fit for intensive therapy. What are the options?
Then we can, after high dose, we can monitor patient if it's she stays in remission. Then
No, no. After diagnosis,
yeah.
you assess the patient, but she
Okay,
is
okay.
not fit
After
for
diagnosis and she's
intensive.
not like, then we can have option of Veneza, venetoclax and azacitidine.
Okay. Is there any blast cutoff for Ven-Aza or not?
It's I think 30%, but it is for because hypomethylating agent is can be given for up to 30% blast.
It's if you are giving the azacitidine monotherapy, then the blast should be
Yeah,
less than 30%.
less than 30%.
Oh, so Ven-Aza, you have the option. So this patient white cell count was up to 60 almost, and you are giving venetoclax. Would you be worried for anything?
Tumor lysis syndrome.
Okay, so what you would do for a tumor lysis syndrome?
I would monitor electrolyte. I will first, before chemotherapy, I will hydrate the patient, monitor IO charting, input, output, and fluid balance, and electrolyte, calcium phosphate, and uric acid monitoring. And if it's like hyperuricemia, if it's hypocalcemia, hypophosphatemia, then I would give initially I would give a prophylactic respiricase. She's female, but I would check G6PD before respiricase.
Usually, we give prophylactic respiricase in a patient who is at risk of developing
Okay.
TLS with IV hydration and 6 hourly monitoring
Yeah.
of the TLS bloods. And that's why the venetoclax regimen is escalating regimen. Uh,
Yes.
you do not start with the full dose on the first day. You escalate it slowly and slowly.
And it is mentioned in the guideline that the first course is given in the hospital if the patient is stable and there is no is there any other complication apart from TLS? Because it's particularly mentioned the first course is given in the hospital and rest of the courses would be on outpatient. First course is on admission and rest of the courses is can be given as outpatient.
Yes, first course of any chemotherapy is given in the hospital because patient is new to it and they
Yeah.
may develop uh, any complication from that. So that's then NPM1 mutation. What type of risk category is that? Favorable, intermediate, or
It is
adverse?
favorable. It is favorable.
Okay. Would you check FLT3 with that?
Yes. If it's positive with FLT3, then it will go into the intermediate category. NPM with FLT3 is intermediate.
Yeah. Okay, so our hospital has acute leukemia workup PDF. I will share that in the group. Okay, let's move.
Amir is there are like multiple predisposing factor for TLS. Is patient count, like in this patient count is 60,000, not very high, not more than 100. Still, patient can go into TLS with venetoclax, or it depends on the predisposing factor,
If the
like
patient
any
has
other.
if the patient has predisposing factor, he can go to TLS even with a small count as well.
Yeah. No, my question is the any role of venetoclax particularly for development of the TLS, because it is mentioned in the like in when where the protocol is mentioned veneza that a patient is might have TLS. Is there anything with the particular with the venetoclax that patient can go into the TLS, or it's just like any other acute leukemia predisposing factor high count patient can go into TLS?
This venetoclax itself has a side effect of developing TLS. Plus
Yes, okay.
high counts, plus if there is any renal problem or
Renal impairment.
patient is dehydrated, that can lead to increased incidence of TLS.
Okay, thank you.
Sorry, so when we start venetoclax, so we give prophylaxis for TLS as well. We start them both.
If someone is at high risk of TLS, then we give them prophylactic rasburicase.
Okay.
Like you may see patient of CLL with 400 white cell count, or ALL whose count is almost 600, 700. And those patients, they are at risk of TLS, so you give them um prophylactic, but sometimes we give them treatment doses as well. If the count is 400 or 500, so they are the very super high category of developing TLS, and we sometimes give them treatment doses as well, 3 treatment doses.
Would you check G6PD in female or not? Or you give
We usually do not check G6PD here because the incidence is very low, and it would take time to uh, for the result to come out.
so is it like we need to mention, because it in the guideline it is written that before respiratory give a check G6PD.
Yes, in the exam you have to mention that, and you have to
Okay.
mention to the examiner for the Viva as well. Okay, so anyone for a third case? This was in the recent exam as well. Anyone?
I will go for then if nobody's coming up.
Okay, right. So this patient is 52-year-old who presented to ED because he is very unwell, and he has high grade temperature, hypotensive, abnormal renal function test, and liver function test. So he was sent straight to ICU for management. The biomedical scientist call you because he has seen a white cell count of 98, and he thinks that this is chronic myeloid leukemia. So this is the blood thin. power 10, a general overview. The power 50,
Um, Amit, can you move to the little bit on the body of the smear because you are on a thin side. If
okay.
yes, it's good.
Now you can report the
Yeah.
question.
Smear shows increased number of white cells, and mainly it's neutrophils. And I can see a few myelocyte left shift, but it's not prominent feature. Myelocyte peak is not observed, but the neutrophil shows prominent eosinophilic granules, and the red cells are hypochromic on this smear. Red cells are hypochromic, and anisocytosis and the platelets are mm, uh, slightly on lower side, but they I can appreciate the platelets. It's maybe it's in within normal range. So my conclusion is reactive neutrophil leukocytosis, um, probably infection. I would suggest D-dimer CRP and monitoring of count in like for the next few weeks. In next few weeks, monitoring of counts.
Okay. So why it is not a CML?
Because I cannot see any basophils, I cannot see myelocyte peak, and there is evidence of infection, inflammation. He's admitted. So at this point in time, I would not go for any further investigation in the lines of CML.
Okay. And why not it is a chronic
Atypical neutrophilic, chronic neutrophil leukemia.
leukemia?
Yeah, but it could be the possibility, but as patient is having clinically is correlating with uh, reactive neutrophil leukocytosis. So right now I will observe the count, um, let the patient is stabilize or improve, and then we can go for if it's a persistent count and with basophilia, or then I can go for CML if it's persistently high.
Don't say like that in the exam that it is a
Okay.
possibility. This is not
Okay.
chronic neutrophilic leukemia.
So
Chronic neutrophilic leukemia has a separate criteria
yeah,
for that. You cannot diagnose it on blood film.
film.
Their neutrophils are mature. They are not
Yeah.
that much toxic granulated,
Mm.
and it has a specific criteria. I think the neutrophil neutrophil should be more than 96%.
80%, I guess.
Yes,
80
and
or
but
80.
and they are all mature neutrophil.
Yeah,
This one has many band forms.
band
Uh,
forms and few
they
myelocytes.
are and they are and toxic granulitic as well. In CNL, they are not like
Okay.
that. What is the mutation associated with the CNL?
No, I don't remember mutation with CNL.
CSF3R.
CSF3R.
Yeah,
Yes.
okay. This is a. They usually ask in the Viva about that if they come to a leukemoid reaction. No. So usually the questions asked from us in exam were report the blood thin, how to differentiate from CML, and what investigation you would like to do next. So the patient
So
was septic.
at this point, with this history, would you mention about investigation for CML? I think
No,
we should
no,
not.
no, no.
No,
This
we
patient is
just.
septic. This patient is
Yeah.
septic, so you have to send the sepsis related investigations. You
Okay.
haven't seen any basophils here, um, myelocytes here,
Okay.
and
Okay.
you're not suspecting CML here. You haven't seen any blast here. The myeloid peak you haven't seen here. So there is no need
Yeah.
of doing uh, CML investigations, and no need to do investigations for CNL.
Hmm.
So,
Yeah.
Dr. Ahmed, in this peripheral fin reporting, we just say that the peripheral finding consistent as should we mention these points that there is no basophilia, no myelocyte peak, and these findings are consistent with the most likely reactive neutrophilia with toxic granulation and would advise for CRP or blood cultures or urine culture. That's it.
Yes, they are done already. So this blood film shows neutrophilic leukocytosis. Neutrophils are having toxic granulations. The red cells are hypochromic with slightly increase in platelet count. The blood film is consistent with leukemoid reaction, most likely secondary to infection. Um, Further investigation would include investigations related to sepsis.
Thank you.
Yes. Then the next part in the exam would be how to differentiate. Like what are the differential diagnosis? This can be a question as well. You can write leukemoid reaction, CML, CNL, but the leukemoid reaction will be the first one. And then if they mention how to differentiate the differential diagnosis or what is the most likely diagnosis, then you will only mention leukemoid reaction because they don't have CML feature, they don't have CNL feature. Yeah. And sometime a question can come with similar picture but um, less granulations, and they would have mentioned somewhere in the history that the patient came to day unit for a procedure. Then that is GSF induced neutrophilia. So going through the history is very important. They give you a lot of tips. So the second last case, any volunteer?
If there is no one is volunteering, then I would
I can
continue.
try.
Okay. Yeah.
So this blood film is a GP blood film, which means the bloods are taken in the GP surgery and sent to the hospital from a 70-year-old man. The biomedical scientist call you because he noticed that the white cell count is 150 and he is worried for acute leukemia. You
Mhm.
call the patient, and the patient says that I have just tiredness and nothing else. So this is the power 10. This is the power 50.
Mhm.
Okay, so now you can report the blood film.
So the blood film findings show in marked leukocytosis with predominant population of atypical lymphoid cells, which are variable in size, small to medium in size, and the small size cells they have high NC ratio, whereas some of the medium size they have scanty to moderate amount of agranular cytoplasm. The nuclear chromatin is condensed, mature, and there are no nucleoli, and some smudge cells are also seen. There seems to be a mild anemia, and the platelet count seems to be mm, a bit on lower side. And the findings are consistent with lymphoproliferative disorder and would advise admission and bone marrow biopsy, bone marrow aspirate and refined biopsy, followed by flow cytometry on peripheral blood for confirmation of diagnosis.
Why would you admit this patient?
for further workup, as you have to do the bone marrow and the flow cytometry, and he's having chest tightness to see whether he has to go for echocardiography or ECG.
No, I said just tiredness, not chest tightness.
Okay,
Mm.
I thought it was chest tightness.
So you're suspecting a lymphoproliferative disorder in this patient. Okay.
Yes.
So what investigation you would advise? What advice you would give to the GP?
To send him to the hematology and for advice for bone marrow biopsy and flow cytometry on peripheral blood for immunophenotyping.
The GP cannot do bone marrow biopsy. Why you are telling him that do bone marrow biopsy?
Okay, then I'll only tell him to send the patient, refer the patient to hematology.
Hmm. So we usually ask them that we will need further blood sample from this patient for flow cytometry to confirm the diagnosis and referral of the patient to hematology unit.
So you don't take sample when the patient will come to you, or you will ask the GP to send further sample.
The GP will send the samples further, or usually we call the patient with such high count and ask the patient how is he. If he can come to hematology assessment unit today or tomorrow, then they usually come there and then we further investigate the patient. The blood film shows leukocytosis. The white cells are mature. There is no blast in the blood film. The platelet count is on lower side, and red cells are okay, consistent with lymphoproliferative disorder. The patient would need further investigation like flow cytometry for the confirmation of diagnosis. Please send the patient to the hematology assessment area or hematology department for review.
So you will not advise bone marrow.
Bone marrow after assessment.
Mhm.
Yeah, because if you are suspecting a lymphoproliferative disease, the flow cytometry will tell you the diagnosis.
Mhm.
What flow cytometry you are expecting here?
Um, BNHL. I would expecting that this patient could have positive for CD19, CD5. I'm not sure whether it's mental or it's because the morphology is not classical of CLL. It could be CLL, it could be mental. Not sure whether it's CLL or it's mental.
So it is CD5 positive and
Mhm.
CD23 positive, 43 positive, and 200 positive.
Then it's CLL.
Okay. And when would you treat this patient?
Um, uh, if the patient is symptomatic, he is having cytopenias and which are not related to autoimmune hemolytic anemia or some underlying pathology other than the CLL. If there is increase in size of lymphadenopathy, and if there is the doubling time uh, is more in 6 months, and there is increase in size of spleen or liver, then you will think of. Otherwise, you will observe if patient is asymptomatic, you will observe him 6 monthly and note down his CBCs.
Yes, if patient develop mesosplenomegalies or bone marrow failure, or if the lymphocyte counts, doubling time is less than 6 months, or the
These symptoms.
persistent B symptoms or progressive B symptoms, then we will decide to treat this patient. What are the bad prognostic features in CLL?
Um, the bad prognosis include the increased doubling time and the presence of TP53, CD38, ZAP70, high TLC count, and I think persistent. I don't remember.
Any mutation molecular?
TP53. Presence of TP53 is associated with bad prognosis, CD38 and ZAP70. And IGHV unmutated is also bad.
What about Notch1?
Notch1 is also bad prognostic marker.
SFB31?
Sorry, which one?
SFB31 and
SLB3.
SF SFB31 and BIRC3.
They're also associated with bad prognosis.
Yes, they are associated with bad prognosis. And which system do you use for staging of CLL?
You do two system, the Rye and the Bennett.
Okay, right. Thank you. The last one. Right, so this is the last case, and I need someone for the who's an exam candidate. Um,
Hmm. Okay, Amir, I will do it.
is there anyone else who wants to go ahead before Shaheen? Captain Alpha is on the top in the list. Dr. SK, and Fathira Aziz, Huma Mansoori.
I can do that.
Okay, good. Yes. So this is a 32-year-old boy, a male, um, who presented to emergency department with uh, tiredness and bruising on the body. So the bloods were taken from the patient, and the biomedical scientist called you because he has seen some abnormal cells in the blood film and increased white cell count. White cell count is 30. So he asked you to come down to the lab and see the blood film urgently. This is Power 10, a general overview of the blood film. This is power 15 now, and these are the cell. Okay, you can report the blood film now.
This marked fragmentation in the red blood cells, occasional nucleated red blood cells, and there are abnormal promyelocytes, few blast cells. The cytoplasm of these abnormal promyelocytes are intensely granular, and findings are compatible with APL. And there are many blast cells as well.
Okay, so you think that this is the APML?
Looks like.
So how would you compile your report for the examiner?
So fragmented red cells, nucleated red cells, prominent abnormal promyelocytes with the cytoplasm containing granules of these abnormal promyelocytes contain the cytoplasm of these abnormal promyelocytes contain granules. There are there are many blast cells as well, which have a high nuclear to cytoplasmic ratio, with the copious amount of cytoplasm as well, containing granules. Findings are compatible, consistent with acute leukemia. Features favor acute promyelocytic leukemia. I would advise urgent flow cytometry, translocation 1517, and DIC analysis, and an urgent referral to hematology assessment unit.
Okay, so the blood film contains leukocytosis with many leukocyte precursors. Most of them are granular, some of them are bilobed, which is consistent with acute leukemia, most likely acute promyelocytic leukemia. This is a hematology emergency which would need emergent assessment of the patient, investigations, and initiation of the treatment. So you are the hematology registrar. You have to tell the examiner that you know that this is emergency. You have to do everything now. You cannot say referral to hematology. No. If you are called about such blood film in the night, you do not say refer to hematology. You go to the hospital at 3 a.m. in the morning to see the patient and to see the blood film by yourself and to explain to the patient what we are expecting.
Yeah, we usually blue light the patient, even if he's at home. We bring him to.
Sorry?
We usually blue light the patient even if he is
Yeah,
at home. We bring him to the ward.
yeah. So the examiner rely on your words that you have written or you have said in the Viva. Uh, they do not know what you are doing in the hospital. They will guess it from whatever you say or you write in the paper. If you mention this is hematological emergency, which would need uh, emergent assessment of the patient, admission, explanation of the probable diagnosis, and initiation of treatment, it means uh, you have dealt APMLs in your experience. Okay. What investigations should be done for this case to confirm the diagnosis?
So I will send the blood urgently to HMDS for fish analysis of 1517 and obviously flow cytometric analysis. These are the urgent investigation. I will send full blood count DIC profile, which includes PTA, PTT, fibrinogens, and D-dimmers. And I would do all the baseline virology and
No, I mentioned investigations to
full
confirm
blood
the diagnosis.
renal profile,
Okay.
liver
Those
function test.
full blood
Sorry.
count, full blood count, renal profile would have been done by the ED. For you as a hematologist to confirm the diagnosis, you will send blood to HMDS for PML aurora stain, which usually take 1 hour to process.
And yes, I will speak someone with the HMDS as well to that the and I will preemptively tell them that a sample would be coming, so which we are suspecting APL. So kindly report it in
You
as
will
urgent.
you will you will not tell the HMDS that a sample is coming. You will hand deliver the sample if it is in your hospital. All the
Yeah,
tertiary
not our
hospital,
hospital. So
all the tertiary hospital have HMDS here.
yeah, but no, not always. You have an HMDS locally. Like we used to call them. We used to be based in
Okay,
and we had to call Leeds HMDS.
okay, okay, right. That's fine. Fish takes 6 hours, so it is a second line investigation. Third one is the PCR, which is the gold standard test. It takes 48 hours. So if you are in hour, you can send the sample or blue light the sample to HMDS for PML Aurora stain. They will tell you the result within 1 hour. Fish will take 6 hours and PCR will take 48 hours. This is to confirm the diagnosis, but you will not wait for the result. If you are suspecting APML on the blood film, you have to start the treatment for the patient after explaining diagnosis to the patient, probable diagnosis to the patient. Right. What is the risk category of this particular patient? He is a high risk or low risk
He's
APML.
high risk.
And why is that?
Leukocytosis, increased white cell count.
What is the cutoff to
I
consider as a high
don't
risk?
exactly remember. Maybe it was 14, 1 4. I don't exactly remember. Or maybe
That
it
is
was
for that is for CMML you were talking
okay.
about, and
Then it was 30, 30.
for APML it is 10. More
Okay.
than 10 it is high risk. Less than 10 it is low risk. Okay. Alright. So let's say this patient is in DIC. What
Okay.
are your targets for the blood components or the blood value?
So if I will transfuse to keep the PT and APTT in a normal range,
Mhm.
uh, and fibrinogen below 1.5, if it's above 1.5, I will give cryoprecipitate, and platelets needs to be kept above 50. So I will give platelets as well if it's below 50. So platelets below 50, and PT and PT raised, PT and APTT raised, and fibrinogen above 1.5. These are the cutoff for transfusion.
Okay. All right. So you think this is APML, it is a high risk category, and patient is not in the DIC at the moment, and you have informed the patient that we are suspecting APML in your case, and you need treatment. What is the treatment option for this patient?
The urgent treatment is when you see the patient, you start him with Dex and Atra with 45 milligram per meter square BT dose, and that's the urgent management for the and for the chemotherapy. Since he's high risk, I'll go for Atra plus idarubicin induction chemo, and then I don't, and I will then console. Yeah,
Okay, so why are you giving DEX?
to prevent differentiation syndrome. He's
Okay,
high.
right.
He's high risk, so probably white cell count may increase further, and he can
Oh,
go.
okay, right. Good. So the patient says that, doctor, is there any side effects of Atra that you are giving me, retinoic acid? So do you know any side effects of retinoic acid?
So, teratogenicity and obviously differentiation syndrome.
Mm-hmm.
Prolonged QT interval is for ATO. I don't exactly remember with this ATRA.
Atra can cause electrolyte abnormalities.
Electrolyte abnormalities, yeah.
Yeah. And electrolyte abnormalities can lead to prolonged QT
Q-
interval. So other than electrolyte abnormalities and differentiation syndrome, do you know any other side effect?
In kids, it can cause pseudotumor cerebri uh, with raised intracranial pressure. Um,
Hepatotoxicity,
yeah.
it can lead to pancreatitis,
Mhm.
bone marrow necrosis as well. Okay. What is differentiation syndrome?
Sorry, my kid is crying. I have to leave. Well, differentiation syndrome is basically when your white cell count increases, it goes into maturation, and this may lead to increased, uh, third spacing of the fluid in the form of pleural effusion, weight gain, ascites.
Okay. What you would do if the patient develop differentiation syndrome?
Dexamethasone and IV fluids, and we need to stop ATRA.
Okay. No IV fluids if the patient has developed weight gain and infusion. And other than ATRA, do you know anything else which can develop differentiation syndrome? This is the last question.
Not really. I don't know.
Yeah. So arsenic, IDH inhibitor like enacidinib, gilternib, midostaurin, they all lead to differentiation syndrome. Okay. All right. So this was the last case. Many people ask on the Facebook and personal messages that they are going for part 2 exam. We need Viva as well. So that's why I increase the number of questions. Anything else before we stop here? Nothing?
Amir, can you repeat poor risk molecular in CLL? Notch, SF3B1, and which was the third one?
It's a BIRC3, BIRC3.
Okay. Thank you.
So next we will meet on Tuesday for part 2 and Monday for part 1. See you later. Take care. Bye bye, everyone.